Hello, my name is Christian Ruff, and I'm here today to talk with you about ACC 2021 for NATF's Clot Chronicles. We had an incredibly exciting virtual American College Cardiology conference this year with some great late-breaking science that really informs our clinical practice. I'd like to start off with a few of the highlights from this year's ACC. First, the Adaptable Trial, which studied low-dose aspirin versus higher dose aspirin, so 81 milligrams versus 325 milligrams for patients with ASCVD. And we know that there's been this debate for a long time whether higher versus lower dose aspirin is either more effective or which one is safer. And this was a big real-world study randomizing approximately 15,000 patients to receive either 81 or 325 milligrams. Most of the patients in this trial were on aspirin prior to randomization, usually the lower dose. And over about 2 years of follow-up, the rate of the composite outcome, which was all-cause mortality, MI, and stroke, was actually similar between the two groups, as was the rate of major bleeding. Now, there's some important caveats to this study. One is that 42% of the patients who were randomized to the higher dose aspirin, the 325 milligrams, switched to the lower dose during the study. And approximately a lower percentage, 7%, switched from the lower dose to the higher dose. And this is important because then we're not sure if whether the similar findings were due to the fact that many patients were switching from the higher dose to the lower dose during the trial, so there were more patients on the lower dose than you would have expected in the start of the clinical trial. So I think there are some important messages. First, that aspirin is effective for reducing atherosclerotic events. At least in this study, there doesn't appear to be a benefit or a risk to either strategy, so both doses appear to be effective and safe. But I think one of the problems of doing a real-world study, and this was using the large PROCORI clinical trial network, simplified pragmatic clinical trial. So it's a real success that the investigators were able to conduct this trial. But one of the challenges of doing these practical real-world studies is this issue of patients staying on the right dose, because that may have limited the applicability of the findings. But a very important advance in our understanding of patients with atherosclerotic cardiovascular disease and their aspirin dose. If we shift gears now to atrial fibrillation, a lot of exciting findings at this year's ACC. One which was with respect to left atrial appendage occlusion during cardiac surgery with respect to stroke risk from atrial fibrillation. And this was from the LAOS 3 trial. And again, these were patients who were undergoing cardiac surgery, and they were studying whether, in addition to whatever surgery they were having, whether they'd get adjunctive left atrial appendage occlusion. And in approximately 4,800 adults with a history of atrial fibrillation who had a risk for stroke, so a CHA2DS2-VASc score of greater than 2, they were randomized to either undergo or not undergo left atrial appendage occlusion during cardiac surgery. And then importantly, all the patients continued to receive standard anticoagulation during the study for their atrial fibrillation. And surprisingly, the risk of stroke or systemic embolism was significantly reduced in those patients who had occlusion. There was approximately a 33% reduction in the risk of stroke or systemic embolism. So I think that's a very important advance in that in patients, there does seem to be an additional benefit of having left atrial appendage occlusion in addition to anticoagulation patients. And again, these are patients who are already undergoing cardiac surgery and they're just performing the appendage occlusion as part of the surgery. Of course, what we don't know is the benefits with respect to doing transcatheter-based left atrial appendage occlusion. And there were some important registry findings actually from a Watchman registry that showed that transcatheter left atrial occlusion with the Watchman device was associated with a low rate of stroke in older high-risk patients at 1 year. But again, in patients who we do the transcatheter approach, they're often patients who are not on long-term anticoagulation. And so what we don't know is whether a strategy for high-risk patients of both occluding the left atrial appendage as well as anticoagulation would be even more effective than one alone. There are some other really important studies, and one has to do with how we treat patients with peripheral vascular disease. And we know that patients with peripheral vascular disease are at a high risk of recurrent events. And we know from the Voyager Pad, which is actually presented last year and published at ACC 2020, we know that low-dose rivaroxaban, 2.5 milligrams twice daily, plus aspirin, reduced cardiovascular events, particularly vascular events, significantly in patients with PAD, about 15%. And now in this follow-up study of Voyager Pad presented at this year's ACC expands those findings to look at total events, because we know that these patients are at very high risk for not just having a first event, but having other cardiac and lower extremity events. And we found that not only did they have more events, but this strategy of low-dose rivaroxaban plus aspirin not only reduced first events by about 14%, but reduced total events by 14%. So again, a very consistent finding that these patients are at high risk, have multiple events, and this strategy is effective at reducing these events. I think an important thing to note is that just the high risk of these patients, that 60% of second events occurred in patients who had a first peripheral revascularization. So we know that patients with PAD who undergo lower extremity revascularization at very high rates, and that anticoagulation with low-dose rivaroxaban plus antiplatelet therapy with aspirin is effective, but particularly in patients who've had prior peripheral revascularization, because they had very high risk of having secondary events. Another, I think, important study with respect to how we approach patients with transcatheter aortic valve replacement. And we know that in patients without atrial fibrillation, the standard approach to antithrombotic management in these patients is usually antiplatelet therapy. And in the Atlantis study, it was a study investigating what would be the optimal antithrombotic regimen following transcatheter aortic valve replacement. And in this study, they randomized patients to either apixaban versus antiplatelet therapy, which was usually aspirin. And some of these patients also had an indication for anticoagulation, say for atrial fibrillation, and those patients would remain on the anticoagulant, either apixaban or vitamin K antagonist. And in this study, interestingly, there was no significant difference in the primary endpoint, which is a composite of death, stroke, heart attack, valve thrombosis, pulmonary or systemic embolism. So apixaban appeared similar to antiplatelet therapy with respect to TAVR. And so I think, what does this tell us? Well, again, first, importantly, these aren't patients with necessarily a guideline indication for anticoagulation. So these results suggest that we don't need to routinely default to apixaban or anticoagulation in general for the default antithrombotic treatment after successful TAVR, that it has no real advantage over antiplatelet therapy. What was interesting in this study is that in a sub-study that looked at subclinical valve thrombosis based on 4D CT, it looked like apixaban had an 80% lower rate of clot formation around the implanted valve compared to antiplatelet therapy. But interestingly, that didn't translate into a clinical benefit in this trial. So I think more work needs to be done to understand why this benefit in leaflet thrombosis doesn't seem to translate to a clinical benefit with respect to hard endpoints. Now, shifting gears a little bit, certainly in the era of the COVID pandemic, was the Inspiration S study. Now, obviously, we're awaiting some of the definitive evidence regarding intermediate versus standard dose prophylactic anticoagulation in critically ill patients with COVID. And this is part of that trial design, but looking specifically at statin therapy, whether atorvastatin is beneficial in critically ill patients with COVID. And obviously, there's a lot of thought that it might be beneficial. We know that statins, such as atorvastatin, are very helpful in reducing thrombotic events in high-risk patients, whether that's MI or stroke or even venous thromboembolism. And we know that critically ill COVID patients have very high rates of both arterial and venous thrombosis. So in addition to anticoagulation, would statin therapy have a significant benefit. And in this study, where they took patients admitted to the ICU, about 600 or so patients, and they looked at this composite outcome of arterial and venous thrombotic events, as well as progression to sort of advanced therapies such as extracorporeal membrane oxygenation, that there was no difference in both the ischemic endpoints or major bleeding. And so it appears, at least with critically ill patients with COVID, atorvastatin therapy was not beneficial or harmful. So again, we don't need to be thinking about statin therapy for the acute management of COVID, but of course, patients who have an indication for statin therapy, there's no reason to discontinue this agent when that patient's hospitalized in an ICU with COVID. And we did learn a little bit more about a topic all of us are interested in, and that's the risk or benefit of alcohol with heart disease. And we know that there's been a debate with respect to, say, heart attacks, whether some moderate alcohol use is perhaps beneficial in reducing atherosclerotic cardiovascular events. And there was an interesting study, Holiday Monitors, which was looking at alcohol consumption and the risk of atrial fibrillation in particular. And this was a very interesting study that looked at whether one glass of wine, beer, or any alcoholic beverage increased the risk of atrial fibrillation, particularly acutely within the first few hours. And this was a very interesting study that looked at 100 patients with either paroxysmal or intermittent atrial fibrillation who had consumed at least one alcoholic beverage in the last month. And these patients wore an ECG monitor, continuously tracked their heart rhythm. Also, other interesting things, they had a transdermal alcohol sensor on their ankle to detect if they consumed multiple drinks, and they were pressed a button on the heart monitor when they had an alcoholic drink. So a very sort of a sophisticated study design. And interesting, the study showed, somewhat surprisingly, that even one glass of an alcoholic beverage was associated with a twofold greater risk of having atrial fibrillation within the next 4 hours. And there was a dose effect. If you had 2 or more drinks in one sitting, there was more than a threefold risk of atrial fibrillation. And so while I still think that there's a healthy debate whether moderate alcohol consumption, 1 drink in women, 1 to 2 drinks in men, may have some beneficial cardiovascular effects with respect to atherosclerotic cardiovascular disease, this study seems to show that any alcohol is associated with a significant increased risk of having an episode of atrial fibrillation. So again, very thought-provoking and certainly food for thought and needs further validation in larger studies, but very important to our understanding of atrial fibrillation and lifestyle. So this was really just a snapshot of some of the incredible science and late-breaking clinical trials at this year's ACC. I'm very excited to share these trials with you and look forward to the next update from a major late-breaking science.